Mito-Canada is energizing lives. We dedicate every day to creating a world where all lives are powered by healthy mitochondria. We support those living with mitochondrial disease with information, initiatives, and opportunities that inspire, empower, and connect. We develop education and awareness programs like today's session to enhance the understanding of mito and improve quality of life. We advocate for those living with or at risk of developing mitochondrial disease. And we fund research that is patient-focused and transformational. This presentation has been made possible through an unrestricted education grant from Ultragenics. We appreciate the support of Ultragenics and thank them for bringing us together to learn. During today's presentation, Dr. Jane will explain exactly what LC-FAOD is, who it affects, symptoms to be aware of, how children and adults are diagnosed, and how those living with LC-FAOD can live and thrive. Now I'd like to introduce you to our speaker. Dr. Shelley Jane completed her medical education at the University of Western Ontario and the Royal College Residency in Medical Genetics at the University of Toronto. She did a Canadian College of Medical Genetics Fellowship in Biomedical Genetics at the University of Toronto. She joined the Edmonton Medical Genetics Clinic in 2012 and is currently an associate professor at the University of Alberta. Her primary area of clinical expertise is diagnosing and treating children and adults with inborn errors of metabolism. Her interests include newborn screening, lysosomal storage disorders, liver transport for inborn errors of metabolism. And now that you've been introduced to our expert, let's start learning. Welcome, Dr. Jane.
Thank you so much, Catherine, for that introduction. And I'm very excited to be giving this talk for this audience. We'll talk about long-chain fatty acid oxidation defects today. So to get started, we're just going to do a little bit of basic review of what these conditions are, who can get affected, and what the signs and symptoms are. And once we learn about the signs and symptoms, we'll sort of go from there, especially to see if individuals are having those signs and symptoms, what to do about that, okay? So long-chain fatty acid oxidation defects are rare conditions that occur when our enzymes or certain enzymes in the body are not working properly, okay? So your body makes energy from fatty acids, but for whatever reason, if that reaction is blocked because an enzyme isn't working, we get accumulation of these fatty acids in our body. And if they accumulate above a certain threshold, we start to see some symptoms, okay? And these symptoms can potentially be life-threatening. So they can actually get very, very severe and affect not only your quality of life, but also quantity of life, okay? They are genetic in nature, in that we have a genetic change that is most likely inherited from one of our parents, but we have two of those genetic changes that then causes this condition to happen. They're metabolic in nature, as in this is how the biochemistry of fatty acids is affected, how we convert it into energy, and that's why it becomes a metabolic disorder. They're very rare disorders to begin with, but the audience here probably knows all about rare disorders because mitochondrial disorders are rare as well, right? And they can affect multiple organ systems. So they're multisystemic in nature. They do not just affect one organ system, okay? So just a bit of that review on some of the lingo that we're going to be using. So we're going to talk a little bit about genes, which we have about 20,000 genes in our body. And think of a gene as a recipe. It tells your body how to make something, specifically how to make a protein, okay? And each gene will often have a very unique purpose. So we have about 20,000 genes that tell our body about 20,000 different things to do. Some of these genes are linked to energy production, are linked to mitochondria, are linked to fatty acids, and so forth. When we have a change in this gene, so a mutation, this can impair how our body makes these proteins. That signal is wrong because we have a genetic change. So that's such, we may have some conditions that are happening because we have mutations in the genes, okay? So before we understand long-chain fatty acid oxidation defects, we really need to understand what fat is supposed to be doing and why we need fat. So we all know about fat, but fat sort of gets this bad reputation because no one likes it, no one wants it. But at the end of it, we have to remember it is one of our 3 major food groups. And as such, it has a big role in what our body needs from it. We need fat. Fat is used on a day-to-day basis for energy, and it fuels many of our very important organ systems, okay? As we're developing, so especially in children, fats are actually used to make different things in our cells, different parts of our brain, our nervous system, and so forth. So they have a big role in actually doing some structural component of our body as well. And also, as we get older, different types of fats will modulate or change the role that a protein plays in different cell functions. So at the end of it, fats are very important, and our body needs it for proper development and for proper energy, okay? So the organ systems that are dependent on fat or the energy that comes from fat are listed here. So your heart, 80% of the time, your heart is using energy that comes from fat. It is beating all the time, of course, and it's taking a lot of that energy from fat. Our liver, brain, and muscle will also be quite reliant on fat. Muscle being probably the second biggest organ that's reliant on fat. So your first 5 to 10 minutes of activity, your muscle will rely on glucose, but then your muscle actually switches over after that 5 to 10 minutes to rely on fat for energy, okay? Your liver actually processes or metabolizes most of the fat, and the brain also uses quite a bit of energy, some that comes from fat. So these are our organ systems that if your fat metabolism isn't working properly, these are the symptoms you're going to see, okay? So really what happens is you have your fat molecules, you have enzymes that convert them into fatty acids. These fatty acids then go through the next process of metabolization, giving you tons of energy. And these energy byproducts are then what the mitochondria would use to produce even more biochemical energy, okay? If these enzymes are not working, your process is blocked, right? It is not taking place. And as such, your fat doesn't get converted into fatty acids. You're not getting the type of energy that you need to support a lot of your day-to-day function, okay? How does fat metabolism occur? So we really have to think of it in a little bit of a different way, because if you're used to hearing some of the mitochondrial talks, fat's a little bit different. We are talking about energy back and forth, but the energy that comes from fat does follow a different pathway, okay? So what we eat in our diet is mostly long chain fats. These have to enter the mitochondria in some way for us to be able to get energy. And the way they enter the mitochondria is by using something called a carnitine cycle. At the end of it, this is a lot of biochemistry, and it's just setting the foundation for you. So if you do not remember these names, that's totally fine. But at the end, when we sort of have a little bit of the foundation, it does help us understand these disorders a little bit better, okay? So we use the carnitine cycle for the fats to enter, and then they go through this other complex biochemical process known as beta oxidation, which basically means you start with long chains, it goes through this machine or steps called beta oxidation, and you end up with medium chain fats at the end, okay? This process, the beta oxidation process, occurs within the mitochondria, okay? The process then generates some byproducts that they go into the energy generation and help the mitochondrial respiratory chain produce some of that energy that we need, okay? So it's all connected, but a lot of it can happen in parallel as well. So this is where it's important to note that long-chain fatty acid oxidation defects, even though we're talking about energy production happening within the mitochondria, these are not the same. These disorders are not the same as mitochondrial disorders. When we talk about mitochondrial disorders in general, we are talking about conditions that lead to the mitochondrial respiratory chain not working appropriately. So that is a primary mitochondrial disorder. That is the job of the mitochondria, which is the respiratory chain. And if you guys know any of your mitochondrial biology, you'd probably know, oh yes, there's a complex 1, 2, 3, 4, 5, and things need to go from 1 to 3 to 4 to 5 to produce energy, right? So that is your respiratory chain. In long-chain fatty acid oxidation defects, that respiratory chain is working just fine. So that part has nothing to do with the fatty acid oxidation defects, but that respiratory chain needs some byproducts that come from fat metabolism. And it's these byproducts that may not be available to the respiratory chain because the fat metabolism is not working in long-chain fatty acid oxidation defects. And as such, you can get what we call a secondary mitochondrial disorder, okay? And this is an important distinction to make for multiple reasons. The genetic basis of mitochondrial disorders and long-chain fatty acid oxidation defects is going to be different. That is, you have different genes causing these different disorders, but also the diagnostic strategies. How we diagnose primary mitochondrial disorders is very different than how we diagnose long-chain fatty acid oxidation defects. And probably the most important is treatment. How we treat these disorders can be very different as well. Okay, so it is that important distinction to make that while fat metabolism occurs in the mitochondria, these are not your typical mitochondrial disorders that we're talking about. And where we can have hundreds of mitochondrial disorders, and we may be like, oh yes, this is this mitochondrial disorder from this one gene, and you may meet 20 other patients with mitochondrial disorders, and they may all have a different reason for their mitochondrial disorder. There's only 6 long-chain fatty acid oxidation defects that we're talking about, okay? 3 of those disorders are when this carnitine cycle is not working well, so we cannot actually get the fat in the right spot, which is the mitochondria. So then you get 3 types of long-chain fatty acid oxidation defects, and their names are listed here. Again, I don't think the names are important. It's more just the category that they fall under. And then we have 3 other disorders which affect part of the beta oxidation. So once the fat has entered the mitochondria, now it needs to be broken down through this process called beta oxidation. And these are the 3 disorders that are, if there are the other 3 long-chain fatty acid oxidation defects. So some carnitine cycle disorders, some beta oxidation disorders. Again, in these 6 conditions, it's the energy generation that gets affected quite a bit. Okay. So let's get into a little bit of the symptoms. I think this is probably one of that more important slide where, what are we talking about? Sure, there's a lot of biochemistry and foundation, but what does this look like? What do long-chain fatty acid oxidation symptoms look like? So we really have to think of the organ systems that are being affected if they do not get that energy from fat. So your muscle is going to be the biggest organ that's affected. So muscle pain tends to be the most common symptom, especially in adults. And with recurrent pain, there may be some weakness that then develops later on, okay? The muscle pain and cramps can be so bad that they lead to something called rhabdomyolysis, which basically means your muscle is breaking down and you're having a lot of production of this muscle enzyme called CK, okay? A lot of our patients also have exercise intolerance because they exercise to a certain degree and then they just get a lot of muscle pain, okay? You can also get cardiomyopathy, so the heart starts to get big. Remember I said heart is a major organ that utilizes fat. So if it's not able to get fat energy, it will work much harder, and as such it gets thicker and thicker and thicker. Okay, that's called cardiomyopathy, and that can be a very concerning symptom in fatty acid oxidation defects. Because the liver mostly is involved in managing and metabolizing these fatty acid oxidation defects, especially in our kids, we can get low blood glucose levels, and that basically happens because you cannot use fat for energy, so all you can use is glucose, and you end up using too much of it, and as such you end up dropping your glucose levels, okay? You can also get hepatomegaly, which is a big liver, and also elevated liver enzymes, okay? but it's the symptoms of low glucose that may be present that you may see. The other ones a doctor would have to diagnose you with, right? You can also get pain in your nerves. So people get this numbness, tingling that they would describe in their hands and feet. And this is often due to peripheral neuropathy, which basically means that the nerves are getting affected because they're not either getting energy from the fat or the cells haven't formed properly because the fat has been deficient, okay? And we also get some symptoms in the eyes. So we can have late onset blindness that often starts with blindness at nighttime and then can progress during the day as well, okay? So if you know your mitochondrial disorders, you will see that there's a lot of symptoms that are common, right, in these groups of disorders. And as such, we're talking about this today because there can be a lot of similarity. And if there are, we may want to consider looking more into this because the treatment and diagnosis can be different. Okay. So, as you probably know, there's a spectrum of every medical condition that we talk about. And in general, the earlier the onset of a condition, the more severe the symptoms are going to be. So if it's present in a baby, that baby is probably going to have the most severe type of condition. Versus say we make a diagnosis in adults, we would say they would have the milder form of the condition. That doesn't mean your symptoms are mild. That just means in general that condition can have a severe form or a mild form, okay? Severe symptoms often require urgent medical care, so the babies may need to be admitted to the hospital right away. They could be quite at high risk of having lots of complications, whereas most of our adults, that may not be a common symptom that they have had where they've required a lot of hospitalizations, okay? Keeping in mind the symptoms are individual, so they will be different for each patient, okay? So in the newborn period, your glucose levels may drop, and that may be the most common symptom or the most worrisome symptom. Whereas as you start to get older, your heart and your muscle may become the major organs that are displaying some of the symptoms, okay? So in the severe form, mostly, as I said, they are diagnosed in kids with low glucose level being the main concern. Sometimes we can see heart changes, and some of these patients will present with change in appetite. They're just not growing on the food that is being offered to them. And that's because they cannot use 1/3 of that food because that's fat for growth, right? So it can affect their growth quite a bit. In Canada, newborn screening will identify most of our long-chain fatty acid oxidation defects in kids if they've had their newborn screening done, okay? In the childhood adolescent form, really the symptoms can be the most overlapping because they can have a infantile presentation but somehow just didn't present in infancy, and we're diagnosing them at 2-3 years of age, or we're diagnosing them at 10 to 12 years of age, and that's such a drastic difference in clinical presentation. But the biggest symptoms will be the heart and the muscle and potentially some changes in their diet that they're presenting with, okay? And then our adult patients actually form a pretty big cohort because they've somehow gone through their first 15, 20 years of life without having symptoms, or maybe they've had symptoms and just not being diagnosed, but it's just getting worse with time. So we'll see our adults tell us, I've had muscle pain anytime I exercised, or it goes up and down. So this fluctuating nature of muscle pain can be a common finding. And they may know that, yes, I get a high CK level every time I get muscle pain, but nobody knows why that's happening. Okay, so that can be a common scenario. These episodes, and important to remember, they're often episodes, they're not there all the time, they really are episodic, but they can last a few days. You may experience some changes in the urine color, so it may become sort of a reddish color or a brownish color, and that's rhabdomyolysis. That is your muscle breaking down and excreting this muscle enzyme through your urine. And you may have some changes in your diet, and you may just find that I don't like fat items. You know, if I have a high fat thing, my stomach hurts, or my muscle pain is going to get more worse if I have something high in fat. And it's not just sort of, oh, I can tolerate all types of different oils, but I don't tolerate something deep fried or something like that. Like it's all types of fats that you would have a problem with. Okay. Important to keep in mind that symptoms of metabolic crisis can occur at any age, and there's often triggers. So an illness is a trigger for fatty acid oxidation defects for symptoms to happen. Not having meals or fasting too long. So, usually everybody would fast overnight, but sometimes if you're sick or have a bad GI illness or just throwing up, you may go 24 hours without eating. That happens rarely, but it can happen. And that's when you may actually get these really bad symptoms of fatty acid oxidation defects. So fasting, especially with an illness, can be quite a big of a trigger. And we've also seen intense exercise. So people are training for marathons or getting ready for something, and then they actually go and do that marathon. So that's training versus actually doing an activity, and the difference in that strenuous activity. All of a sudden they did the marathon and now they have symptoms a day later or 2 days later, something like that. Okay. So here, if you're having symptoms like this, it is very important to keep a record, to talk to your physician about it, because these can be some of those symptoms that we want to know about that may help us in diagnosing a long-chain fatty acid oxidation defect. The adult forms of these conditions are called myopathic forms, and that's just because most of the times it's the muscle that's affected. And the 3 most common conditions that we may see, so remember we said there's 6 long-chain fatty acid oxidation defects, but the ones that will often present in the adult are CPT2, VL-CAD, or LCHAD. So the other 3 conditions really have more of a childhood onset symptomatology. Okay, these conditions, these 3, can also have childhood onset, but they also are more known to have more of an adult onset phenotype as well. Okay, the triggers are the same. So this is a bit of that repeat prolonged activity, especially with fasting or infection, can be a trigger. The symptoms are recurrent muscle pain, this darkness of the urine known as myoglobinuria, poor endurance, so you're okay to exercise for 5 minutes, but not 50 minutes, that type of difference. And with time, you start to develop some muscle weakness, okay? You may not have symptoms in between, and that actually is a very important thing to know, because in many of our primary metabolic or mitochondrial disorders, that muscle pain is almost always there. It doesn't go away. It gets worse with things, but it doesn't go away. Whereas in fatty acid oxidation defect, it actually can go away completely. So that's something good to keep in mind, that that's an episodic type of a muscle pain. But as always, the milder the form of the condition, the more difficult it is to diagnose. So we really have to stay on top of these symptoms to even raise a suspicion of these types of disorders. Okay. So how can we diagnose these? There are multiple ways of diagnosing long-chain fatty acid oxidation defects, and I'd like to say most of it's available in Canada, but of course, we are a provincial healthcare system and we have different medical centers in the country, so care can be a little bit different depending on where you are. But if we start with the first one, which is newborn screening, newborn screening started in about 2006 to 2007 in Canada. Again, it's provincial, so every province started newborn screening at a slightly different time, but that's sort of that overall range. And it's, if you have kids who've gone through newborn screening, but if you don't, really newborn screening is testing babies at the time of birth for certain conditions, and the testing is done in the first few days of life. And these conditions are usually serious health problems, but if we detect them before the child has any symptoms, we can drastically change the health of that child, to a point that often newborn screening is saving lives, because if we miss that condition and the child presents with symptoms, there's a much higher rate that that kid may pass away. Okay, so that's why newborn screening has been fabulous for many of the disorders. And for fatty acid oxidation defects, it allows us to make that diagnosis before the child gets in trouble with symptoms. And as such, it does drastically decrease the mortality in babies that we used to see with fatty acid oxidation defects. Okay. Most provinces are screening for all the long-chain fatty acid oxidation defects, but again, I cannot say that as 100% because newborn screening programs will change from year to year and they're provincial in nature too. Okay. Newborn screening is collected through a blood spot, so it's a bit of a long card, and towards the end you have these blood spots that you drop a blood spot on, so a drop of blood, and it just becomes a spot. It gets transported to a lab, and that lab then runs the test for you. Okay, and it's usually collected after 1 day of age or 24 hours, and usually in that 1 to 3 days of life is when newborn screening gets collected. Okay, so outside of newborn screening, how can we diagnose these disorders? So say you're an adult and you're questioning symptoms, how can we get testing done? So this is called biochemical testing, and it's usually happening on a blood sample, okay? And basically these are some complicated metabolic names, but the confirmatory testing is called acylcarnitine test. And this will actually tell you if long-chain fats are accumulating in your body. So it's not a common test. Not a lot of physicians would know about it, but this is how we diagnose fatty acid oxidation defects. They should be collected fasting. So you've gone through an 8 to 12-hour fasting, and then you get this collected. And if you're questioning a fatty acid oxidation defect, we would recommend doing it in combination with some things called carnitine, glucose, the muscle enzyme known as CK, and liver enzymes, okay? Of course, if those are abnormal, we can either do some genetic testing or some very specific biochemical testing, but really this would be the first test to start with and can be a fairly good test, okay? The highest yield for diagnosing a long-chain fatty acid oxidation defect by doing acylcarnitine is when you're having an episode. So if you're in muscle pain, you're having an episode, your CK is elevated, and you get an acylcarnitine profile done and it's negative, that is pretty good in saying you probably do not have the condition. So that's how good this test can be if it's done during symptoms. But if it's done outside of symptoms, it can be negative. Okay, just because, especially in an adult, we're looking at a mild form of the condition. If they feel completely well in between their symptoms, well, that's probably because the long chains are not accumulating to the same degree in between symptoms, and as such they're not having symptoms. So of course, if they're not accumulating to the same degree, we're not going to pick them up through doing that acylcarnitine test, which is really looking to see if long chains are accumulating or not, right? So if biochemical testing is done when you're well, it may be negative, and as such, if we still have a clinical suspicion, you know, there's a history of multiple episodes of rhabdo, but the episodes haven't happened in a couple of years because now that individual's just not exercising or has already made some changes to diet or whatnot. Like sometimes we make lifestyle modifications so that those bad symptoms don't happen, right? So if that clinical suspicion is still there, we can do genetic testing. Okay, genetic testing for long-chain fatty acid oxidation defects is very good, but you have to have a pretty high suspicion. It's a blood test, but because these are rare disorders and genetic testing is even more rarer, we often have to send these types of tests out of province or out of country, which means that somebody has to pay for it, which is our government. So it can require a bit of a process to get approval for genetic testing, but it is available in most of our metabolic centers for sure. Okay. Now we've talked about these are genetic quite a bit. So let's just spend a little bit time understanding what that really means. So these are what we call autosomal recessive condition, which means that we have to have 2 changes in our genes for this condition to happen. Okay, so let's take a step back. Mom and dad have 2 copies of each gene. Kids have 2 copies of each gene. So say we talk about one long chain fatty acid oxidation defect. A dad has 1 working copy and 1 non-working copy. So dad is carrier. They carry a genetic change, but the other copy is working fine. And mom is the same way. Mom's also a carrier. Carriers are asymptomatic. They would never know they have a predisposition to have kids with a certain condition because they themselves are going to remain asymptomatic because they're one working copy, the other copy is not working. Okay. Well, when they go on to have kids, the dad can either pass on the working copy or the non-working copy, and you have no control over what you pass on. So it's basically random. So when you look at this photo, if you have two carrier parents, you have a 25% chance of having an autosomal recessive condition in your next pregnancy. And that's how a long-chain fatty acid oxidation defect is inherited as well. Okay, so if an individual has long-chain fatty acid oxidation defect, their parents are most likely carriers and their kids are going to be carriers as well, because if you have the condition, well, both of your copies are not working. So you can only pass on the non-working copy. So all of your kids are going to be carriers for that condition because they get their second copy from your partner, right? So if an individual has long-chain fatty acid oxidation defect, their siblings have a 25% chance of having the same condition because they come from the same parents. Okay, so I hope that sort of autosomal recessive pattern makes sense a little bit, and I can answer more questions, or if there are any questions, I can answer them later. Okay, so is there a time or place, or how do we get tested? That type of thing, of course, always comes up towards this time of talk, because we've talked about what the symptoms are. We've talked about how can we get tested. I'm like, okay, well, how do I go ahead and do that, right? So if there are symptoms, especially of exacerbation of muscle pain with illness or prolonged exercise or activity or things like that, those are the symptoms that we want to know about. And maybe you've had your blood tested for your CK enzyme at that point and it's elevated. Those would be the key symptoms that we want you to recognize, and that those are the symptoms that we want you to go to your family doctor or your other types of doctors to get advocated to get tested. And mostly that's because we have specific treatments for these disorders. Long-chain fatty acid oxidation defects are considered treatable conditions. So once diagnosed, there are things we can do for your health to make sure those symptoms are better. And if not better, at least they don't get worse. Okay, so that's why it is important to get tested for these disorders. Is there time that you should be getting tested? Basically, you can get tested anytime. The preference, of course, is to get tested during an episode because it's most likely that we will get the best results during that time, whether we want to rule the condition out or make the diagnosis. Okay, so for a positive or a negative test, it's a best time is when you're having symptoms, but otherwise there's no age, there's no specific time of the day or anything like that. Fasting is the best, but you could be fasting during the middle of the day and that's still acceptable. Okay, how to get tested? I think you can either get referred to a metabolic center, you can talk to your family doctors. The biochemical testing, anybody can order, anybody can organize. It's just that most doctors wouldn't know what an acyl carnitine is or what a carnitine is. Some of our patients, we've been referred from the neurology team or the neuromuscular clinics, and these are specialist doctors who are often looking after patients who have muscle pain, and these clinics do know what acyl carnitines are because they've diagnosed them for our patients for us. So those are also another avenue, especially if patients are already involved with those clinics, that conversation can be had with those physicians too. Okay. So really, if you have a long-chain fatty acid oxidation defect, you are part of a big team from multiple different subspecialists who see you. Now, what does it look like if you have a diagnosis of long-chain fatty acid oxidation defect? Once the diagnosis is made, we try our best to control your symptoms, which usually means our kids getting all the way to adulthood, we are able to avoid any learning difficulties. So most of our patients do not have learning difficulties. Even though exercise is such a trigger, we still recommend exercise. So our patients can participate in sports and regular exercise activities as long as we can manage their risks, as long as we can set a treatment plan around that. And of course, that has to be on an individual basis. Patients with fatty acid oxidation defects can have kids, they can work full time. They just have to take, really the biggest thing is this extra precaution during illnesses or periods of high stress, okay? Our kids require a lot of hospitalizations because kids just get sick a lot more frequently, but some of our adults also go in and out of the hospital. You know, if you just moved homes and you have a fatty acid oxidation defect and you picked up a whole bunch of boxes, you're gonna have pain, and those are the type of triggers that happen in adult life that then may lead to hospital admission, okay? We manage our fatty acid patients with multiple different things. So lifestyle, diet, illness management, and sometimes activity management. So this is what treatment looks like for our patients. Really depends on how severe the form of your fatty acid oxidation defect is. Some of the key things that we do is avoid prolonged fasting. So our patients who have a diagnosis of fatty acid oxidation defect, we do not let them, or we recommend they do not go beyond 12 hours of fasting. So we limit how long they fast for, okay? We ask them to maintain an exercise routine because we want the muscles to be working, but we don't want them to overexert. Fluids are super important, but also so are calories. So we don't want you to eat too much, but we also don't want you to eat too little because it's all about energy production. And if the body sees there's not a lot of energy, it's going to try to break down a lot of fat. And if you have a fatty acid oxidation defect, that's when you're going to get symptoms, okay? Some patients require dietary management. So most of our kids who are diagnosed on newborn screening, because it's the severe form of the condition, we would have to restrict the fat that they eat from their diet, and this is long chain fats, okay? They may need some special formulas or medications, and these formulas or medications would contain something called medium chain triglycerides, which is just a smaller form of the fat. So it's not a long chain fat, it's a smaller chain fat, because we still need energy from fat, but we cannot use the long chains. So you bypass the block and you give the kids some medium chain so that they can use that for energy production from fat, okay? If we're starting fat restriction, it tends to be lifelong for those who need it. And as such, diet management can be challenging. You cannot just walk out and eat a pizza because that may be too much fat, okay? If you have the severe form of the condition, your fasting requirement may be very little. So some of our kids can only go 4 or 5 hours at night and they have to wake up and eat something or drink something. You need to have lots of snacks and fluids with exercise. And before your longest fast, which tends to be bedtime, that snack becomes very important because that's sort of going to last you that 6, 7, 8 hours if needed. Okay. Whether you're whether you have the severe form of long-chain fatty acid oxidation defects or the mild form, illness management is always a key because this is the biggest trigger. So with illness, we say decrease the fasting time, take extra calories, restrict your fat, take extra medium chain. And we may some patients just take medium chain fats when they're sick because they know that's a trigger. So they may not require fat restriction outside of illness management, but we may restrict their fat when they're sick. Okay, and of course, drinking lots of fluid. Sometimes you may require hospital admission when you're sick, just because your CK levels are going so high, and we really need to give you different types of calories to be able to make sure that we can turn that episode around. Okay. And then activity management. Some of our adults only need activity management, of course, on top of an illness management plan. So they may not need fat restriction, but if they're going to go run a marathon or go skiing or something like that, they may need a high protein or carbohydrate snack before. They may need some medium chain triglycerides for their activity. They may need to drink a lot of fluid. So we come up with this plan and be like, all right, if you're going to exercise for 60 to 90 minutes, use this plan so that you don't get into trouble or you don't get symptoms. Okay, and that generally works really well. So what can you do? Of course, you are the advocate for your own health. So, we want you to keep excellent food records and activity plan records and when your symptoms are occurring. And you also really want to have a clear expectation type of a conversation with your care provider as to what would you like, what are your goals for your care. Be open if the management is too challenging. we recognize that dietary restrictions can be very hard, or activity restrictions can be very hard. So all of these things, be open with your caregiver or your physician, because it's very easy for me to come up with a plan. And it's very easy for a patient to say, sure, doc, I got it. I can do this. But it really is hard to say, no, doctor, I don't have this. I cannot do this. This does not work for me. And if you don't tell me that, I'm going to assume, okay, we're all good to go. But if you tell me that, then I will come up with ideas that do work, because the goal at the end is to keep you healthy, keep you fit, and make sure you have the best quality of life, right? So in summary, long-chain fatty acid oxidation defects are rare disorders. And today we really just talked about 6 disorders very specifically. There are specific treatment strategies, and these will lead to improved health outcomes. And symptoms overlap with general mitochondrial disorder. So this is the challenging part with respect to diagnosis, that there are a lot of overlying symptoms. So not all patients who are having mitochondrial symptoms need to have diagnostic testing for fatty acid oxidation defects. But at the same time, if you have a fatty acid oxidation defect, we don't want to miss it, because your treatment will be different than potentially what is the treatment for your mitochondrial disorder. Okay, so I will stop there, and I will hand over the reins to Catherine, who will moderate the question and answer session.
Okay, wonderful presentation. Thank you so much, Dr. Jane. You made it really easy to understand, and that was a lot of information to go through in a really short period of time. So we do have quite a few questions. So I'm just going to start working through them. The first question is this something that would be caught in whole exome testing? Do we need to ask them to look for a red flag specifically for this kind of defect?
Yes, this will be caught in whole exome sequencing. You do not need to ask them specifically to look for this. So exome covers fatty acid oxidation defects very, very well. So if you're questioned to have a mitochondrial disorder and your metabolic genetics doctor has recommended an exome, you will pick up a fatty acid oxidation defect. So yeah, we're pretty confident that exome will not miss these types of disorders.
Okay, perfect. Good to know. Would the adult onset forms be found in newborn screening?
Yes, they can. So as we're learning more so think about this. So 2006, 2007 is sort of Canadian experience with newborn screening. So most of those patients are just in their teenage years if we diagnose them in 2007, right? So, again, most of the adults we're diagnosing right now have never gone through newborn screening because it didn't exist at that point. But yes, I have a lot of patients with VL-CAD, LCHAD, CPT2 who are the milder form, but we're picking them up on newborn screening, and we follow them through childhood, and we learn in the first few years that this is not the severe form of fatty acid oxidation defect that we see in kids. We're not expecting symptoms, and yes, this is the mild form that we have picked up. So absolutely, newborn screening will pick up mild forms, but it's not 100%. So it can also miss mild forms. And the reason it can miss it, that it's not the goal. Newborn screening's goal is not to detect a mild adult onset form. The goal is to detect the severe form. So while it can pick up a milder form, it can also miss a milder form.
Okay, great. Is there a type of formula you would recommend for a newly diagnosed CPT2, and I would imagine for the other forms of LC-FAOD as well, for a new infant who has mild form?
So really you have to talk to your caregiver, right? So if it's a mild form of CPT2, do they need a formula, a specialized formula or not? So that's the first question. If they need a specialized formula, well, are you doing just a formula, or are you going to also do a typical diet, whether that's breastfeeding or baby formula on top? So that's going to change the selection that you have. Because for some families, we only do our metabolic formulas and they're not having anything on top. So then you have to pick different formulas, because remember, for kids, most of their nutrition comes from the formula. So it's not just that we have to look after the fat portion of it, we have to look after the protein portion and the carbohydrate portion, and the kids have to be able to tolerate it. So, we only have a couple of different formula options out there, and some of them have a different ratio of long chain to medium chain. And really, it's your dietitian and your healthcare provider in discussion with them. You decide what's the ratio we need for our child, depending on the severity of their condition, and as such, what the best formula is. There's not that many options, so it's really more to do with how restrictive or how severe the form of CPD2 is. But not all kids with a mild form of CPD2 require formula. The problem is we don't know that in the first few months or first few years of life. So we'll often are on the side of caution and potentially be very aggressive with treatment so our kids don't get into trouble. And then, a few years later, they haven't had a hospitalization. They've done really well. They've never dropped their glucose levels. And then we're like, okay, well, now we feel a little bit more comfortable that this is a milder form. But until you know that, these are conditions you don't want to get symptoms with. That is absolutely what you want to avoid in a baby. You don't want symptoms. So we will often be a bit more aggressive to keep that child as healthy as possible.
Okay. The first part is if I'm an adult who suspects that I have an LC-FAOD and I've been tested when I'm not in crisis, will the disorder show up, or should I try to get a diagnosis when I'm in crisis? And then the second part of that is there's another question that how can I get my family doctor to refer me for one of these tests?
So let's talk about the referral bit first, maybe. So really, I think the family doctor, the type of things, they can refer you to a metabolic genetic center. So either a genetic center or a metabolic genetic center, whichever is closest to you. The things that this would trigger for you to see a metabolic geneticist would be muscle pain, elevated CK levels, episodic in nature, questioning long-chain fatty acid oxidation defect. Okay, now the center that you're being referred to, they may say, oh, we don't need to see this patient, have them do fasting acyl carnitine and carnitine. If those are normal, wait for symptoms to happen or whatnot. But it is true that if you've had testing done in an asymptomatic stage and you go through periods where you have no symptoms and have symptoms, it is best to get tested in the symptomatic stage, because if you have negative testing when your CK is elevated, that really rules out long-chain fatty acid oxidation defects. So this is where sometimes that whole question of genetic testing may happen, because you can get genetic testing done even if you're asymptomatic. That's not a biochemical test. Your genes are your genes. They are not going to change whether you have symptoms or not, right? So that's when, if the suspicion is high enough, genetic testing may be questioned, and that's not a family doctor decision. Of course, you have to talk to your metabolic doctor to decide that, or your neurologist.
Perfect. And I'm going to paraphrase this next one. Hopefully I get it right. I think the question is, as someone who's planning on having children. So I have a sibling who has an LC-FAOD. I am considering having children and am worried that I may be a carrier. Should I be getting tested before I decide to get pregnant?
If you're worried, absolutely. So this is where you get referred from your family doctor to a genetics clinic. You share your family history. The genetics clinic is going to need records if, whoever in the family has fatty acid oxidation defect, if they've had genetic testing or not. But absolutely, we have tested siblings or parents all the time, because they want to know their carrier status and they want to know their risks. So absolutely, that's an option available. And if you're worried about it, get tested. If you're not worried about it, it's not a requirement.
Perfect. Okay. So that's the last question that we're going to have time for. And on behalf of Mito Canada, I'd like to thank you, Dr. Jane, very much for sharing your insights and expertise with us. It was a fantastic presentation. Just loved it. Also like to thank Ultragenics for providing the funding through an unrestricted education grant for us. Finally, we'd just like to remind you that Mito Canada is here for you. Please visit mitocanada.org regularly as new content is being added all of the time. So once again, thank you very much for joining us. And this concludes our session. Have a lovely day.